I think there's a couple of prior landmarks I'd like to highlight. So the first is the IMvigor10 trial, which, as we know, was a prospective phase 3 trial, which assessed the efficacy and safety of atezolizumab, adjuvant atezolizumab post-radical cystectomy for the management of muscle-invasive bladder cancer. We know that that was ultimately a negative study, that we did not notice a significant disease-free survival benefit in the main cohort. However, there was an exploratory analysis after, where a subgroup of patients who were circulating tumor DNA positive at the start of therapy did seem to derive a disease-free survival benefit from adjuvant therapy with a hazard ratio of 0.59. However, to emphasize, this was just an exploratory endpoint. And then I think another major landmark was the Christensen cohort. So they were a group that examined ctDNA kinetics at various time points prior to neoadjuvant therapy, prior to cystectomy, and then post-cystectomy. And they found that ctDNA positivity correlated very well with pathologic response or lack thereof, and was also highly prognostic during the surveillance period. Positive ctDNA predicted frank radiographic relapse by a median of 96 days, which was very interesting. Absolutely. And to our knowledge, this is the largest of its kind, but it's a retrospective multicenter analysis of a cohort of 122 patients with muscle-invasive bladder cancer who underwent radical cystectomy. They had circulating tumor DNA assessment during what we defined as an MRD period, which was either 12 weeks post-radical cystectomy or before initiation of adjuvant therapy, and then a subsequent surveillance period. Most of our patients had pure urothelial carcinoma. Not many had variant histologies. About 50% of the cohort had clinical stage 2 disease at the time of diagnosis. Approximately 50% of the overall cohort did receive neoadjuvant therapy, and most of those patients received standard of care chemotherapy. At the time of radical cystectomy, the majority of patients had either complete or partial pathologic response to neoadjuvant therapy, and about 61% were node negative, and ultimately 41% proceeded to adjuvant treatment. And so, and as I mentioned, to our knowledge, this is an expanded real-world validation, but to our knowledge, this is the largest of its kind to examine the prognostic value of ctDNA kinetics during the post-cystectomy and surveillance period. At the time of the first surgical time point occurred at a median of 54 days, and 65% of patients were ctDNA negative at that post-surgical time point. We found that 97% of patients who remained ctDNA negative post-cystectomy showed no evidence of recurrent disease. 63% of patients who were ctDNA positive at any point during the cutoff period did demonstrate clinical evidence of recurrence, with a median radiographic lead time of about 61 days. I think it's very consistent with the prior prospective studies, and particularly the Christensen cohort. I think it corroborated that very well in a more expanded setting. I think just talking a little bit about the current treatment paradigm. So as we know, in patients who have received adjuvant chemotherapy in muscle-invasive bladder cancer and underwent radical cystectomy, the current recommendation is for adjuvant immunotherapy in patients with residual pathologic disease, at least PT2 or node-positive disease, or consideration of cisplatin based chemotherapy or immunotherapy in patients who did not receive neoadjuvant treatment, who have at least PT3 disease or node positive disease at the time of definitive surgical management. Multivariate analysis of our data revealed that ctDNA positivity at any time post-radical cystectomy seemed to outperform pathologic staging with respect to predicting shorter disease-free survival in a statistically significant fashion. So I think this suggests that ctDNA status post-cystectomy can provide really valuable context to clinicians when assessing the risks versus benefit of recommending adjuvant therapy. And we know that this is a question that's currently being assessed with the IMvigor11 trial. And so my understanding of the setup of IMvigor11 is that they're basically stratifying patients post-radical cystectomy by ctDNA positive status versus not, and then proceeding with adjuvant atezolizumab for those patients who are ctDNA positive. And so I think that's obviously a prospective analysis that will likely definitively potentially corroborate or not corroborate our observation in our real world analysis that ctDNA positivity did seem to predict shorter disease-free survival. As I mentioned, this adds some really valuable context when having discussions with patients about adjuvant treatment, particularly in patients who the recommendation standard of care may be cisplatin-based therapy, which we know can add a lot of additional toxicity to a postoperative course. And so I think for patients who have pathologic node positive disease, it's always a little hairy whether you want to skip adjuvant treatment totally. But I think, and hopefully IMvigor11 will validate this. But I think it's certainly a valid option in patients who are ctDNA negative to give strong consideration to omitting adjuvant therapy. So I think, from my perspective, at least, I think more robust validation of ctDNA as a marker of disease control in the metastatic setting in patients who are on systemic therapy. We know that there's a lot of evidence that, it can predict positivity can predict recurrence with a significant radiographic lead time and potentially lead to change in therapy if possible. So I think a more expanded cohort would be interesting, specifically focusing on that question. And then I think also incorporating upper tract urothelial carcinoma patients and potentially including more variant histology bladder cancer patients as well, to see if our thoughts on the ctDNA kinetics and its validity as a biomarker also pan out.